Hi, everyone. Welcome back to the next episode of the Clinical Topic series. And today we are going to talk about ACS or Acute Coronary Syndrome. All across the world, I think chest pain is one of the most common presenting complaints to the emergency department. And when somebody complains of chest pain, naturally, one of the main concern is if it is a life-threatening diagnosis, like acute coronary syndrome. So we have Lakshay with us, and we'll fire the first question. And what exactly is acute coronary syndrome?
I think that's a great question to start with to clarify what ACS actually means. So ACS or acute coronary syndrome generally covers three diagnostic entities, which is STEMI, ST elevation MI, and STEMI, non-ST elevation MI, and the third one is unstable angina. I'm talking about a little bit in more detail all these three, how we make the diagnosis. So STEMI is when you have obviously ST elevation on the ECG with a good story, then you call it ST elevation MI. I'm saying you should have a good story because there are many things which can cause ST elevation on the ECG, and it's not always myocardial infarction. So good story with obviously ST elevation, typically focal or localized ST elevation on the ECG with reciprocal changes, should be called as STEMI and should be treated as STEMI until proven otherwise. Talk about NSTEMI, which is non-ST elevation MI, and you will probably have some elements of good story there, and you may or may not have ECG changes. You should have a positive troponin or a positive cardiac biomarker.
Mhm.
And ST elevation MI, you don't need cardiac biomarkers or troponins to call STEMI. But in NSTEMI, you should have a positive cardiac biomarker test, typically troponin, and you may or may not have ECG changes. And unstable angina, so it's sort of similar as NSTEMI. Good story, heavy focus on story here. You should really have a good story, may or may not have ECG changes, and troponin or any other cardiac biomarker should be negative. So it's not enough damage to cause a bump or a rise in troponin.
Okay, perfect.
So
That's
that's unstable angina.
okay. Yeah, that's I think a very good brief summary of all the components of ACS or what's called as an ACS. So before we head on further, can you talk a little bit about what are the risk factors for ACS? What are the traditional risk factors, and what are some of the non-traditional risk factors for ACS?
I think the non-traditional. I'm glad you're talking about this. Non-traditional risk factors don't pay enough attention to that.
Mhm.
Everybody knows about traditional risk factors, which is your age, premature history of heart disease in family. You've
Mhm.
got previous history of heart disease, diabetes, high blood pressure, smoking, excess alcohol consumption. There are a fair number of non-traditional risk factors, which sometimes often we don't ask or we don't check, uh, but they are helpful and they give you enough risk to have, they put you at enough risk to have an acute coronary syndrome or a cardiac event.
Mhm.
These are, I'll mention a few of them. So chronic kidney disease
Mhm.
can hasten the whole process of atherosclerosis, the CKD.
Mhm.
Systemic infections, sepsis,
Mhm.
especially there was a recent chat about COVID or influenza, they can turn your stable plaques into unstable because of profound systemic inflammation,
Mhm.
often related with the cytokine storm.
Mhm.
Sepsis or typically related with COVID and influenza or other viral illnesses. Uh, Severe sepsis is a risk factor. CKD is one. Pregnancy is another risk factor. It gives you quite high risk of having cardiac events, which you only don't think pregnant lady with chest pain. Sometimes you think of PE as the first thing, or reflux or pneumonia, but ACS is they are also at high risk of acute coronary syndrome,
Mhm.
especially if they have a cardiac event. They often have a coronary dissection rather than a ST elevation MI. The other non-traditional ones would be anything related to vasculitis or SLE or rheumatoid arthritis,
Mhm.
even use of any other inflammatory states like HIV is again a risk factor for acute coronary syndrome. Long-term cocaine use also hastens your atherosclerosis. So these are really the key important non-traditional ones: CKD, SLE, rheumatoid, any other vasculitis, HIV,
Okay.
chronic steroid use,
Mhm.
and chronic cocaine use as well, and pregnancy.
Okay.
We should it's worth checking these with the patients, and that should at least gauge your suspicion of ACS. Now, the other thing about risk factors is they don't, if your history is good enough, or if your history makes you worried, if somebody doesn't have risk factors, I would probably not pay too much attention to that.
Okay.
Because what happens sometimes is, now I'm sitting here, I don't have any risk factors, don't have diabetes, traditional or non-traditional. If I get chest pain, if I go to the emergency department, my ECG is normal. Does that put me down to zero risk? I still have risk.
Yeah.
So a lot more attention should be paid to the history, and our decision, we should consider risk factors, but we shouldn't use them alone to make any decisions. What I'm saying is people with zero risk factors can have acute coronary syndrome or a STEMI, and then you might find, oh, he was a diabetic, oh, he was his blood pressure was high, or he had long-term high cholesterol or familial hypercholesterolemia, that sort of thing. So something bad happens, and then you hunt for risk factors, then you find some.
Yeah.
But at the first place, you might say, oh, he never had risk factors. That's why we discharged him home.
Yeah.
And then he came back with significant cardiac event. So definitely check for them, and they will influence our decision making as physicians. But we should also look at the patient, look at the ECG, obviously history. And again, history alone cannot rule out ACS.
Yeah.
So it's looking at the whole picture together.
Perfect. Good that you spoke about the history and the importance of history. So let's get into the history itself. So obviously we know that if we are suspecting if somebody is having a ACS, then they classically present with cardiac sounding chest pain, which obviously is
typical.
Typically described as left-sided chest pain radiating to the left arm. Although if you look at the studies in the literature, it's probably radiation to bilateral arms, or the right side is more common or more specific than the radiation to the left arm. So is there any other components of the history that would be looking at which would make you think more worried about this person might be having ACS?
Yeah, again, I will go into them, but again, none of them by themselves rule in or rule out.
Yeah.
So if you are worried, if you have any worry, you should send a troponin or do serial ECGs. And like anytime you do serial ECGs, you have to send a troponin. You can't send it 3 ECGs and discharge him, but into a troponin.
Yeah.
Serial ECGs and troponin, that's our best bet. That's the best way to evaluate them.
Yeah.
In terms of things that put you down to low risk, and I say low risk, not zero risk, and they are reproducible chest pain, pain which is sharp in nature, pleuritic, positional pain. Things that put you at high risk are pain which radiates to both your arms, bilateral radiation to right side, as you said, is more specific. And pain associated with sweating. Now, very often patients say, oh, I was sweating with the pain, but they look totally fine, 25-year-old, and then again, no risk factors, and pain-free, normal ECG, again, no traditional or non-traditional risk factors. It doesn't take us anywhere. So, but observed sweating is more important rather than reported sweating. So observed sweating, nausea, vomiting, feeling dizzy, sometimes pre-syncopal as well, but bilateral radiation, nausea, vomiting, observed sweating, and pain which is described as heavy or somebody sitting on the chest. These are really the big and bad ones that put you at high risk.
Yeah. Perfect. Thanks for clarifying the fact that although these are, if you mentioned many of the low risk factors, but none of them exclude or rule out ACS if you're thinking about ACS. Is it correct?
No, that's correct. Again, I used to think age helps, but I think I'm now doing this for the last 10 years. And the youngest one I've seen is a 25-year-old who had tombstones, massive anterolateral MI, and he was wheeled in by his father. It's quite tragic. So age, again, you don't, restrict. It does put you higher age, old age does put you at higher risk, but again, young age doesn't always mean zero risk. I think at minimum, we should get ECG, which is non-invasive and quickly obtainable bedside test, easily repeatable,
Yeah.
But at minimum, we should get ECG. And if there's any concern, any historical elements which make you worried, you should get a troponin
Yeah.
for them, which should be, again, interpreted carefully. We are unfortunately in the era where we are doing too many troponins, I feel.
Yeah.
And again, they should be, interpreted in the light of history, because troponin is an excellent test. And it is very, very, very sensitive now, highly sensitive or ultra sensitive.
Yeah.
And that also means it is very non-specific. Whenever you increase the sensitivity of a test, its specificity drops. It's like pretty much becoming like D-dimer. So we should interpret it in the light of history.
Perfect. Okay. Let's talk about bit more about unstable angina. So if a patient comes in with chest pain, and if the ECG is normal, and if you send a troponin and that's normal as well, would you rule out ACS, or would you still think about unstable angina if your history is really good?
I think the history is good. I would just call it unstable angina.
Yeah.
After I get the troponin. So obviously you said the ECG said it's normal or non-specific. So definitely it's not a STEMI.
No.
So with a decent story, so it's either NSTEMI or unstable angina.
Mm-hmm.
If the troponin is positive, that means NSTEMI is negative with a good story.
Yeah.
Then yes, it is unstable angina. And typically they are admitted for an expedited cardiac workup, angiogram, and sometimes you discharge them, but they should be relatively pain-free, sensible, appropriate follow-up arrange within a matter of a couple of days, 2 or 3 days, but almost always I've seen them, they get admitted and see cardiology.
Okay.
Next day, talking about historical features of unstable angina, they often have, so it's different from chronic, predictable, stable angina, where you get pain on exertion, settles on rest.
Yeah.
Unstable angina is when you get increased frequency of episodes of pain, or pain occurring at rest or minimal exertion, which is, and the patient is going to tell you, this is totally different. I used to walk like half a mile, but now I can barely walk a few steps.
Yeah.
I get this pain. It can be associated with sweating, feeling sick, nausea, vomiting, feeling cold and clammy. It may last a little bit longer than your typical 15-20 minutes. But increase in frequency, resting, it's also called as crescendo angina, worsening in terms of frequency of episodes and the intensity of pain, and often typically described as occurring at rest or minimal exertion. So that's unstable angina. If that has a negative troponin, that then becomes unstable angina. If positive, then it's called as NSTEMI.
Okay, perfect. Can you talk about a little bit about what are the tools or the scores which are available for risk stratification of chest pain in the emergency department?
I think there are 2 or 3 which come to my mind. One is the most popular that has come in the last 2-3 years is the heart score, or the heart pathway, which is a little bit different from the heart score. Just tells you what to do, whether to admit them for observation. I think it really, and the other one is there's a Manchester score from Manchester. There's an EDACS score. There are a few more that are used in the US, but I think heart score is the most easily, it's most easy one to remember. The mnemonic is heart.
Yeah.
It also depends what your hospital, what's been agreed by the cardiologist and the emergency department, what you should be using. So it should be a score that has been studied in the specific emergency department population. And typically these are used for low risk people. If somebody has got high enough risk, then yes, it'll be difficult to send somebody home who's got 4 comorbidities.
Yeah.
Even the troponin, if it's not, even the delta troponin, it's not significantly gone up.
Yeah.
You should either speak to cardiology or get them seen over the next couple of days.
Yeah.
And if they're known to cardiology, if they've got few risk factors, if they've got something bad that has happened in the past, that really becomes a high risk chest pain, and it's hard to discharge them without speaking to cardiology or arranging rapid follow-up for them.
Okay, perfect. I think we have covered most of the important things. Just to summarize everything, so if you're suspecting ACS, lots of focus on the history, and if there is a good history of ACS, assess the risk factors, look at the ECG. If there is ST elevation, that is STEMI or ST elevation MI, If there is not, there are two possibilities. One is NSTEMI, if there are non-specific changes and positive troponin. If the ECG is normal and if the troponin is negative, and if you're still thinking the history is good for ACS, it is branded as unstable angina, and they should still get assessed and treated for the same. Is that correct?
No, that's correct. And in the NSTEMI or unstable angina, ECG can be rock solid normal, or it can be it can show some non-specific STT changes. Yeah.
Perfect. I think we have covered important topics inside the ACS paradigm. And I think we'll meet you in the next session with a new topic. Until then, goodbye.